There are 4 components to caring for a patient with asthma, so we're going to go through those now. The first component of care for asthma is assessment and monitoring. To do that, we're going to assess asthma severity to initiate the therapy by using a severity classification chart and assess both domains of impairment and risk to determine initial treatment. Then we're going to assess asthma control to monitor and adjust the therapy by using the control chart to determine if the therapy should be adjusted. We're going to step up if necessary, and we're going to step down if possible, and use multiple measures of impairment and risk, obtaining lung function measurements by spirometry at least every 1 to 2 years or more if needed. And we're going to also schedule a follow-up care every 2 to 6 weeks while gaining control every 1 to 6 months depending on progress of control, and every 3 months if a step down in therapy is anticipated. The second component is education. We're going to provide self-management education by teaching and reinforcing some self-monitoring, proper medication technique, and avoiding environmental triggers. We're going to tailor the education to the literacy level of the patient so that they understand, and we're going to appreciate the potential role that the patient's culture, beliefs, and practices may have an effect on the education, so we need to keep that in mind as well. We're going to develop a written asthma action plan in partnership with the patient. So we're going to agree on treatment goals and address the patient's concerns. We're going to integrate education into all points of care where healthcare professionals interact with the patient. So by doing that, we're going to provide instructions for daily management and managing worsening symptoms of the asthma. We're going to involve all members of the healthcare team, and we're going to encourage education at all points of care, and that's including the clinics, emergency departments and hospitals, pharmacies, schools, and the patient's home. And we're going to use a variety of educational strategies and methods. Our third component is control environmental factors and comorbid conditions. So we're going to recommend measures to control exposure to allergens and pollutants or irritants that make the asthma worse. To do that, we're going to determine the exposures first, the history of the symptoms while being exposed, and the sensitivities. In patients who have persistent asthma, use skin or in vitro testing to assess sensitivity to the indoor allergens as well. We're going to advise patients on ways to reduce exposure to those allergens, pollutants, and irritants. We're going to advise all patients and pregnant women to avoid exposure to tobacco smoke. And we're going to consider allergen immunotherapy by specifically trained personnel. This is for patients who have persistent asthma that is triggered by a specific allergen only. And we're going to treat the comorbid conditions by considering especially the allergic bronchopulmonary, the GERD or the gastroesophageal reflux, obesity, patients with obstructive sleep apnea or with rhinitis and sinusitis, and those patients with stress or depression. We're also going to recognize and treat all of these conditions because they will improve the asthma control. And we're going to consider inactivated influenza vaccines for all patients over the age of 6 months old. Our fourth component is medications. We're going to select the medication and delivery devices to meet the patient's needs and circumstances. To do that, we're going to use stepwise approach, which I'll go over that later, to identify appropriate treatment options. Inhaled corticosteroids are the most effective long-term control therapy, And when choosing among the treatment options, we need to consider the domain of the relevance to the patient, the impairment and risk, or both, patient's history of the response to the medication, and the patient's willingness and ability to use the medication. So we need to make sure the patient can actually understand how to use it and that they can do it at home whenever they're going to be alone by themselves, so they understand how to do the medication. Now I'm going to go over the stepwise approach. The stepwise approach is a guideline that is used to assist the decision-making of treatment of asthma, and its goal is to achieve and maintain the control of asthma. The stepwise approach breaks it down in age and in category. So we'll start with the first being the general principles of all age groups. So this is going to apply to everyone, no matter what age group or category they fall in. So they're going to incorporate 4 components of care, which we just went over. That includes the medication, education, environmental control measures, and management of the comorbidities in each step, and monitor the asthma control regularly. We're going to initiate therapy based on asthma severity. So for patients not taking long-term controlled therapy, we're going to select a treatment step based on the severity, and for the patients who have persistent asthma that require daily long-term control medication. We'll adjust the therapy based on asthma control by monitoring the level of the asthma control and adjust the therapy accordingly. And we'll refer to an asthma specialist for consultation or co-management if there are difficulties achieving or maintaining the control. Next group is the ages 0 to 4. We'll consider daily long-term control treatment for young children that may be at high risk for severe exacerbations, yet low levels of impairment between exacerbations. We'll monitor response closely and adjust the treatment as necessary. We'll initiate daily long-term controlled therapy for children who have had 4 or greater episodes of wheezing in the past year that lasted greater than 1 day and affected sleep, and who have a positive asthma risk profile, which is either one of the following: a parental history of asthma, physician diagnosis of atopic dermatitis, or evidence of sanitization or aero allergens, or 2 of the following of sensitization to foods, and 4 or greater % blood eosinophilia or wheezing apart from colds. Also, with the age group of 0 to 4 years, we're going to consider daily long-term control for considering initiating the daily long-term control therapy for children who consistently require the short-acting inhalers, treatments of greater than 2 days per week or greater than 4 weeks. Children who have 2 exacerbations requiring oral systemic corticosteroids within 6 months. We'll monitor response closely and adjust treatment. If no clear or positive response occurs within 4 to 6 weeks and the patient's medication technique and adherence are satisfactory, we'll stop the treatment and consider alternative therapies or diagnosis. If clear benefit is sustained for at least 3 months, consider a step down to evaluate the continued need for daily therapy. And children this age have a high rates of spontaneous remission of the symptoms. Next age group is ages 5 to 11 years. We'll involve the child in developing a written asthma action plan. We'll address the child's concerns, preferences, and school schedule whenever we're selecting the treatment. We'll encourage the students to take a written copy of the asthma action plan to school and their after-school activities so that their teachers and everyone can be informed of the plan as well. We'll promote physical activities and treat exercise-induced bronchospasms. step up the therapy if the patient has poor endurance or symptoms during normal play activities. We'll monitor the disease progression and loss of lung growth, and treatment will not alter underlying progression of the disease, but a step up in therapy may be required to maintain asthma control. Next age group is ages 12 and over. We'll involve youth in developing a written plan as well. Same as the previous age group, we'll address their concerns, preferences, and school schedule. And we'll also encourage them to take a written asthma plan with them to school and after school activities. And we're going to promote the physical activity for them as well. We're going to step up the daily therapy if the child has poor endurance or symptoms during normal daily activities. We'll assess possible benefits of treatment in the older patients. We'll establish reversibility with shortened course of oral systemic corticosteroids. We'll adjust medications to address coexisting medical conditions common among older patients. So, for example, we'll consider calcium and vitamin D supplements for patients who take the inhaled corticosteroids that have a high risk factors for osteoporosis. We'll increase the sensitivity to side effects to bronchodilators with increasing age. So as the patient gets older, they have an increased sensitivity to some of these medications that we may be giving them for their asthma. So we'll want to make sure that there's not going to be any conflict with any other pre-existing problems that we are causing with our asthma treatment. So we just want to be aware of any of that for their arthritis, for their hypertension, their glaucoma. All of those could contraindicate what we're doing with our asthma treatment. So we want to be aware of that. All right, our next category is the exercise-induced bronchospasm. Our goal is to prevent the exercise-induced bronchospasm by treatment strategies of long-term controlled therapy, so their maintenance drugs, and a pre-treatment before exercise. So they'll take a short-acting inhaler like albuterol before they exercise, and or they can take the leukotriene receptor antagonist as well. Now, frequent or chronic use of the long-acting maintenance inhalers, that's not for pre-treatment. It is discouraged to use that as a pre-treatment inhaler because it can disguise the poorly controlled persistent asthma. And we'll also encourage the patient to warm up before exercise with a mask or a scarf over their mouth if the weather is real cold. Next category is pregnancy. We're going to maintain the asthma control throughout the pregnancy by monitoring the control during all prenatal visits. Asthma tends to worsen in 1/3 of women during pregnancy, but then also improves in 1/3 of women in pregnancy. So we'll have to monitor the control throughout the whole pregnancy, and we'll adjust the medications accordingly. Now, a lot of people wonder if asthma medications are safe to take during pregnancy, but it's shown that it is safer to be treated with asthma medications than to have poorly controlled asthma throughout the pregnancy. So maintaining lung function is very important because you want to ensure the oxygen supply to the fetus. Albuterol is the preferred short-acting inhalers, and inhaled corticosteroids is preferred long-term control medications. Budesonide is preferred because more data are available on this medication during pregnancy. All right, our last category is surgery. Our goal is to reduce the risk of complications during and after surgery. We're going to assess asthma control prior to surgery, and if the lung function is not well controlled, we're going to provide medications to improve the lung function. And a short course of oral systemic corticosteroids may be necessary for those patients. For patients receiving the oral systemic corticosteroids during 6 months prior to surgery, And for selected patients on high dose of inhaled corticosteroids, we're going to give 100 milligrams of the hydrocortisone every 8 hours IV during the surgical period, and reduce the dose rapidly within 24 hours after surgery.